our bare minimum was we are not sharing specimens. If you read that clause very well, but for specimens for testing, we are not sharing specimens for genetic testing. Number 2, we have agreed if we have to share data, it has to be aggregate, anonymized data that has gone through the laws of Kenya, and the laws of Kenya agree for us, including consent. Subject consent is part of the laws of Kenya. Under data protection, the data belongs to the subject. Even consent is, you see, when you look at Data Protection Act, below it is everything, including the consent of the patient.
Hey there, and welcome to Fanya Mambo Africa. This is a very exciting episode today, and it's very critical for Kenyans because the Kenya-US Health Framework deal has been released to the public to see, and there are a lot of questions about it. And for us to understand what this means for us as citizens and the country at large, we brought Dr. Thuranira, who's an advisor on matters health to, is it State House or the country at large?
The Executive Office of the President.
Which is
by
State
extension,
House.
Kenya.
Okay, fantastic. Good to have you.
Thank you.
And to see you after such a long time.
Thank you so much.
Karibu sana Alfa
Thank you
House.
for the Alfa House. I'm happy to be here.
All right.
Yeah.
Straight up into it. This Kenya Health Framework, there's a lot of questions. You guys are auctioning our data as citizens, and we're not happy about it. Why are you auctioning our data? Or health data for that matter?
So thank you for the question. And unfortunately, people have misunderstood the deal. So the Kenya-US cooperation framework has been in existence for quite a long time. We have had a long-standing relationship between the two countries for over 25 years, spanning through the USAID project, PEPFAR projects that were Presidential Emergency Fund for HIV and Relief. We have gone through long-standing partnerships in health, in education, most other sectors.
Yeah.
Agriculture, they have been supportive and everything. So as you all know, when the current president of the US, Donald Trump, once he came into power, there was a stoppage of the USAID project. We all know the benefits that the country was accruing from USAID. We look at commodities. They used to support commodities here in medical products for HIV, TB, malaria programs, the activities around it, human resources for that. They used to support development of data systems. They used to help us in surveillance of diseases and such. So that has been going on for quite a long time. Mm-hmm. Now the stop work order has come in, the funding has been cut, but the government decides to draft what in their own interest they call American First Global Health Strategy.
Yes.
And they clearly outline the areas that they want to support under the new framework for the government of the US. So they look at surveillance, they look at data systems, they look at commodities, they look at human resource and the modes they want to support. So as such, once that has been drafted, several engagements, I'm lucky to be part of one of the engagements that was there in September in New York at the sidelines of United Nations General Assembly. We met the team from the Department of State, Global Health Strategy, and we were able to understand. That was like a week before earlier they had launched the strategy. We had a lengthy discussion about that, and they said that they have reorganized what we call USAID funding program. Mm-hmm. They have reorganized it now into what they are calling the American First Global Health Strategy under the presidency of Donald Trump. And as such, we had to come and draft what we call a cooperation framework and other attendant documents. So in the cooperation document, the negotiations have been going on for more than a month. Mm-hmm. Kenyans might not believe that, and I'll echo my colleagues' words, that Kenya has brilliant minds. Kenyans have people civil servants, public officers who hold this country's interest at heart. And a lot has been said over what has been going on. So negotiations have been going on. We had our strong positions. The Americans had their strong positions. We had to come to an agreement. And as such, the breakdown of it was to agree on, first, what programs they want to fund. Mm-hmm. So nearly the same programs they used to fund. They used to fund surveillance. They used to fund training. They used to fund commodities. They used to fund healthcare workers. That's what we call human resources for health. They used to fund data systems and such. So we agree on the funding. So we have agreed on the money. Now, how will this money come? Funds flow. How will this money come? Previously, they used to fund through what we call implementing partners and NGO. The government position is, if you want us to improve our system, you are coming in to help us and support us for the next 5 years for us to transition. So 5 years will come and will come to an end. We'll be 2021, we'll be done with US funding. So what better thing?
2031.
Sorry, 2031, thank you. So what a better thing than to support our existing institutions to grow, so that at the point where you are exiting, you leave us with institutions that have grown, that have learned, and have done everything. So the government position is that it becomes direct government funding. So money is channeled from the American government direct into a national treasury, direct into line item under the line ministries and such, that is healthcare. We discussed that we need to account for this money. Mm-hmm. And for you to account for this money, we set performance indicators for every. If you look through that deal down there, we need to reduce maternal mortality annually by 95%, such. The existing number is 355. We need to go down up to 70, the figure that is globally acceptable by WHO over 5 years. We need to reduce our neonatal mortality rate. We need to reduce treatment of malaria, the malaria cases to go down. So we have performance indicators. So how do you show that you have reached a target? You give your statistic, isn't it?
Yes.
So you come and say, according to my assessment, the maternal mortality rate has gone down from 355 to 200. But you have to account to that person. It's a cooperation agreement. I have to prove to you that actually that it is 200. What do? Is I account for that by giving even data evidence. Now, what kind of data are you giving? The data is within the confines of this agreement. So if you are supporting us in reduction of maternal mortality, when I am accounting to you, I need to tell you that actually in the year 2026, 2027, this number of mothers per 100,000 died due to preventable or non-preventable causes. But how do I package that data? I do not tell you Sarah, A, B, age 30, no. We give you anonymized data. So you develop a code of anonymizing data. Mm-hmm. So you can say XX1, female of the reproductive age, died because of severe bleeding.
So that confirms either way we have to give the data.
We have to account for, it's a cooperation agreement. You understand? Mm-hmm. So you have to account for the utilization of money, and you account with it with statistics. And how do you give these statistics? Let me give you a simple example. Currently, the Americans have been supporting us in surveillance for quite a long time.
Yeah.
They've been supporting us in outbreaks, viral hemorrhagic diseases. They have been supporting us in polio outbreaks. They have been supporting us in COVID time. We have all been tested. Samples have been given out. You understand? We are also required as a nation to account even previously to WHO. We give WHO data, isn't it? So I keep on wondering why, and this data, you're not going to give raw data. This is aggregate data that have been, I'm struggling to give, it is aggregate data that have been consolidated, all the unique identifiers removed, and as evidence of 300 mothers have died.
But aggregate data comes when you have tested me, you, him.
Now, walk away from testing. Let's talk about deaths.
Yes.
So we have 100,000 deaths in the year. I really don't have... Telling you a mother called A, B, C, D and giving you does not help you. But saying 100,000 and the evidence of it as an accounting mechanism of the identified data of the 100,000 that has no unique identifier and everything as an accounting mechanism. That's number one. Number two, if it is testing, we have an outbreak. Remember, American or the rest of the world, we have interest in what is going around everywhere. We travel to the US, they travel to us. They are tourists here. We should know what is going on in the ecosystem. They should know what is happening.
So they will also share their data on request.
Yes, on request.
So if you request, you can get American data about, let's say they have an outbreak.
Yes.
Because from the document I have read,
yes,
if there's an outbreak, you need to report to the US within 7 days.
So that is a national, is a national public health policy, what you call 717.
Yes.
7 days of detecting an outbreak, 1 day of reporting, 7 days of determining what it is, following it up, contact tracing, and everything. It's called 717 policy. You understand? So basically that applies everywhere. Does not even apply to Kenya only or American only and everywhere. It applies in all. It's a public health strategy for disease surveillance, detection, and follow-up. You understand? So we live in a global village.
Yes.
It is good for even Americans to know that currently there's no ongoing outbreak in Kenya.
But if they have an outbreak, you can demand for their data.
We need to know. We travel there, they come here. So it's more of, that's why it's called a data sharing agreement. That we agree that the sovereignty of the country must be recognized. So data in Kenya belongs to the subject. Thuranira belongs to Sarah, the subject. Are we together up to there?
Yes.
If a request is put in for us to share data on maternal mortality to justify the targets, that we have reached the target so that we continue the cooperation agreement. First things first, let's walk backwards. We have to look at the request, make sure it conforms to all the legal and regulatory requirements of this country. Digital Health Act regulations, the Kenyan Health Act, Data Protection Act, and any attendant law. You understand? That's why during the drafting of this agreement, the Office of the Data Protection and the Data Commission was actively involved to the point that she went through the data sharing agreement and gave her consent in writing that this, if signed as is, I am comfortable. We have protected the subject. We have protected the nation. We have not sold our soul to the world. You understand? So when the request comes in, it has to go through the normal. So a request has come in. So it comes in through the Cabinet Secretary's office, goes to the Director General, looks at it. It is taken to the Data Protection, Data Commission or the Attorney General's office. They say, this data that has been requested is within limits of what is allowable. Data should be given as A, B, C, D in this mode and this formula. If you give this data this way and you hand over this data this way, it protects the nation, protects the subject, protects everyone. And it is shared.
So essentially...
But in case there is a statement that in case we are in disagreement over how they want the data and how we want the data, we said the laws and the regulations of Kenya, in case we're in conflict, actually the statement says in case there is conflict, the laws of the land, so Kenya, supersedes everything else. So if their requirement is share data on what, depending on how the requirement comes in, and we come here and we tell them, no, our law only allows us to share this way, this way, this way, this way, and we have a conflict, say, no, me, I want this way, no, they want this way. It is the law of the land that. So Kenyans should be rest assured that I am Kenyan, I have children, I have a family. I would feel very bad sharing mine. Why would I seed that should be shared for everyone?
Why do you think then Kenyans feel unsafe? Because if, for instance, today, let's say I'm tested with HIV/AIDS and they need information about something about HIV, maybe there's a regeneration of some sort.
Or a strain.
And yes, and you share, but you did not consult me, and it is my data.
Fantastic.
What does the patient's charter say?
Very good. So why is there a lot of uproar in the country? So unfortunately or fortunately, during the period of negotiation of this contract, several draft agreements were shared. Not only were they shared locally, but they were shared from other countries, whose source we cannot trace. So a lot of bad documents circulated, unfortunately. You remember at the same time they were negotiating with Kenya, they were negotiating with the neighboring countries, they were negotiating with actually more than 55 countries. You understand? Yeah. So different forms of different documents circulated. You see, that document was generic. It never had a country's name. It never had anything. So even I could develop a document in my house and circulate it for malicious reasons. I mean, there's a lot of politics around that whole space. So that document became the documents of discussion, and there were different forms of it, and I think it brought a lot of uncertainty. During the process, and I'm very happy, and I would allow the teams that were negotiating, the government teams from Council of Governors, Ministry of Health, Attorney General's Office, Office of the Data Protection, National Treasury, under the leadership of the Cabinet Secretary, they sat down, went through this process rigorously, sometimes leaving offices at midnight, sometimes waking up very early in the morning. I remember the last few days we didn't sleep. We went through like 3 or 4 days of crunch time because we had a government position that we were not moving. Our counterparts had their position that they needed to go and consult, so we gave them. Our Cabinet Secretary chaired a meeting which he gave the actual government position. And it was a do or die. If you take it or leave it, we will leave. We have not been here. And further diplomatic discussions and everything, and people ceded ground, and people agreed on mostly, but the bare minimum positions were not there. Now, that agreement that was circulating, unfortunately, had very bad wordings and everything, that there shall be a data sharing for over 25 years. So the first thing is that Kenyans have heard that we are sharing data for 25 years, yes. Isn't it?
Yes.
Now, the second thing that Kenyans have heard is that this data, upon request, it shall be shared.
Yes.
There is no governance, there is no... Tukiitisho tunapeana. Kwa sababu tunapewa pesa.
Yes, because I have the document that
Very good.
CS shared.
Very good. Yeah. No, we'll go through that document.
Yes.
Tukiitisho tunapeana. Then number 3 is that there's nothing we are getting in return. Mm-hmm. We had to put the legalists, and the Office of the Attorney General and the Data Protection are very supportive in putting the legalists around what data can be shared. Mm-hmm. There is a statement there saying that the maximum allowable something, I wish I could open that document, on the data protection, says it's personal de-identified.
Yes, that de-identified is used so many times.
Yes, information that shall meet the standards of Kenya under the laws of Kenya, something of the sort. There's a statement like that one. That's legalese. So basically, we have to meet all the criteria of the nation for the... So that brought a lot of anxiety. I mean, civil society started talking, data protection experts started talking, gave their inputs on it. And unfortunately, or fortunately, we signed the deal on Thursday. The team had to travel back. No more government protocol. Who assigned the document is the Prime Cabinet Secretary and the Minister of Foreign Affairs. The document is still in was still under their arms. So it had to be in writing handed over to the ministry, who's the parent owner of the document, in writing. Mm-hmm. So it lands at the Cabinet Secretary's desk. The Cabinet Secretary even went ahead, during this duration before sharing the document, he went ahead and explained what are the contents of that one. But Kenyans insisted, we want to see the document. So yesterday at about 4 p.m., the Cabinet Secretary shared the document widely on his social media platform. It just circulated everywhere. We are still receiving comments. I'm happy monitoring. The people are very loud. Some of them have seen their sentiments. This is actually not the document that was signed. People are not expecting. So I've seen two kinds of documents. Kenyans were not expecting the cabinet secretary to share the document. He shared the document. That is the document that was signed. That's the first thing. But the second thing is that there are people who are saying, this is not one you guys signed. But why? Why would you share? Even the Americans, they will be very mad at us if you are sharing the document that is not the document that we agreed upon. So we shared the actual document. It has the old cooperation framework. Then it has a separate document, the data sharing agreement. And I would wish you to discuss, to look at the nitty-gritties of it.
5 additional terms, duration. This agreement shall enter into force on the date of signature by both parties, shall remain in force for 7 years.
Very good. Now, let me answer you.
You've told us 5 years, but the document says 7.
Now, the laws of the Land Data Protection Digital Health Agency require that you store data for 7 years. Mm-hmm. Even this data that you're recording here, isn't it? So, it's the duration of storage of the data. You have understood? Mm-hmm. So, while the sharing of the data shall be within the confines of the duration of the framework agreement, which is 5 years, mm-hmm. you are required to have stored that data for then 7 years. Even data that we collected today, you can be assured that data will be collected. It will be stored for more than 7 years, but the bare minimum requirement, even as per the law of storage of data, is 7 years.
Okay.
Yes.
That you've explained.
Correct.
Why was there no public participation, especially because it involves people's data? At the end of the day, if today I'm tested HIV, it's my data you will be sharing.
Correct.
Either way.
Correct.
So why was, or even if not the public, the parliament?
So our whole process is coming up, unfortunately, because of the structures and the requirements of us engaging in this bilateral. The leadership of this country is a representative of the people. Our cabinet secretary is chosen to be the cabinet secretary of Kenyans. Officers who work in different ministerial positions, officers who work in different offices are representative of Kenyans. So let's not assume that they do not represent the interest of Kenyans. That's the first thing. But this process went through a lot of back and forth and necessary regulatory requirements. It's a discussion that has been held at the highest office, including in cabinet. Now, we have agreed, we have drafted a data sharing agreement, we have signed it. It needs to come and through the ratification process. It has to go through, it is at the AG has gave approval. It has to go to the Parliamentary Committee of Health. Remember, there are budgetary implications to that. It has to go through Senate. There are budgetary implications to that document that was signed. Those are the representatives of the people.
So
they'll have to...
You've worked backwards.
No. So the point is, we had to agree first. Okay? Mm-hmm. And Treasury was part of the discussion. And Treasury will not say, if they could not afford, they would have just told us, this one we are just dreaming. They just tell you this one we can't afford. But you look at the duration of time, we say progressively we're adding 10 billion or 15 billion, 20 billion. This one you can afford over time. Actually, we knew we were supposed to have transitioned all these things. Today is when we needed all this money, actually. But the Americans have been gracious enough to come and say, we want to give you another 5 years of this cooperation agreement. There's some little money that we have. We want to co-invest with you people as we transition through this process. Do you understand?
Wait, before we go to the 208 billion.
Very good.
This is supposed to be funded by Kenya's budget, technically.
This whole space was being funded previously until the stop work order. Let me take you back. The USAID project, all these you're seeing that is there, was even previously being funded.
Yes.
So it's a continuum of what they stopped. So what they did is that they stopped that one and they say they want to rearrange this framework agreement to fit into the American First Global Health Strategy. So if you read the American First Global Health Strategy, they choose the areas of interest, which seem mostly to be the same old areas of interest.
Yes.
That's the first thing. But they are very categorical that they don't want to fund through NGOs and third-party entities and everything. So in reorganizing that whole space and reorganizing the cooperation agreement, all these structures are to be set. Okay?
But now how is Kenya signing something, then coming to ask for budget after?
No.
How sure are we will have the money?
So part of the negotiating team, if you walk back and see the delegations who they have met, there was a meeting at National Treasury. You can see our Cabinet Secretary, Honorable Duale, co-chairing a meeting with the American Ambassador, the SHA, and the Cabinet Secretary, National Treasury, and the Principal Secretary, National Treasury. So all the relevant teams were involved in this process. So Treasury comes and tells you, actually looking at my projection, looking at what I've factored in, the MTEF process, the budgeting process, I can give this money slowly. We have been given 5 times. Looking at our projection, we can commit this in writing.
We can commit.
Yes, this government has committed many things.
That's an assumption, though.
Yes, but it has committed in writing, isn't it? And said that we have been given 1 year grace period not to put in any money. During this 1 year, we work around our budget making process and transition process. And as we plan for 26-27 budget, we start looking at, we are required to put in 10 billion or 15 billion or 20 billion. So we start the process of budgeting now in advance. And we prove to the Americans that our co-financing amount is, we have put here so that they put this one. Remember, it's a cooperation agreement. So it's co-financing.
Was the Committee on Health involved in that? And are they sure from their experience? Because the Committee on Health obviously
a lot of consultation has gone through. They kept on being briefed on what is going on. Of course, they would not sit through the negotiation team and everything. It was very hectic, but they kept on being kept abreast on what is going on. And they said, once you finish that process of signing, now let's come and discuss it. Treasury knows, Treasury has committed, Committee of Health has to you have to justify why you need this money. You have to build up a justification so that they also go and justify it. It's not just, Treasury just don't allocate, you have to plead your case. So we say part of the government's obligation, international obligations, is that we need to do a co-financing or counterpart financing input into this agreement. Okay. So we need to set aside like 10 billion. We have done that. Let me tell you, we do that for vaccines annually. So there's an amount that UNICEF gives us, there's an amount through Gavi, and there's an amount Kenya has to give.
But it's a thing.
So we have done it, and every year there's a requirement from us, and we have to go to Parliament and explain to them, we need vaccines. Oh, we have been given this amount of money from development partners. We need this amount of money. Kindly justify or go defend it in Treasury, because you have to go through the parent committee.
Yes.
You understand? We have done it for family planning. We have done it for commodities. We have done it for human resource. We have done it for all other sectors. So it's a routine thing that has to be done. This year we'll be going to defend family planning budget.
In addition to?
Yes, in addition, we shall be going to defend immunization budget. We shall be going to defend.
Okay. I understand the budgeting process.
Very good.
Now, the US...
You are reading the data,
I am reading.
Data sharing. Very good.
I'm still into it. But
Yes.
the US has put in $208 billion.
Correct.
And we know Trump is a businessman. Trump never goes somewhere where there is no interest. That's obvious. He even says it himself. So what is in it for the US? Because there is no way they just sat down and decided, oh, Kenya, we need to put our money here.
Sarah, I think we don't believe who we are. We are a serious country. Out here, everyone thinks we are a very serious country. Maybe it's us who don't think we are a serious country. We are a country that is admired, even amongst our peers. We are a country that people look up to. We are a country whose opinion is sought. We are a country that everybody wants to associate with. I mean, look through the presidency of His Excellency the President, William Samoei Ruto. How many presidents have visited us? How many states visits have we been invited to? Look at how many missions we have in this country. How many people want cooperation agreements with us? How many engagements have we had as a country? Probably it's only us who don't appreciate ourselves. So the question is, why did Donald Trump have interest in investing in Kenya? What interest does he have? So far, he has not shown any, because the interest might be what? Business?
We have to know, because Trump is not Biden.
Understand? Business? Nothing so far. Nothing so far. They have been supporting those structures before. They were part of the cooperation agreement that we have as a country. I tend to think this is not the only thing that Trump will do with Kenya. Probably health, we are the first people who have ran and reached the table and finalized. He might come with other arrangements in agriculture. He might come with other arrangements in education. He might come with other arrangements in... So we expect this one to go beyond. So maybe time will tell if he had interest. So far we have seen none, and I don't think you have seen any. Have you seen any?
I cannot justify that Trump has zero interest. Personally, the way I view...
Okay, that's all I'll say, probably.
Even generally the US. The US always gets into countries where they have interests out there.
So, okay. No comments.
No.
Let's wait and see. So far, we have seen none.
Mm-hmm.
Maybe we might be here in a month's time discussing no interest or interests. You understand? But so far, it is the arrangement that was there. It has been there during Bush's time. It has been there during Biden's time. It has been there through Obama's time. I have not seen the interest of those last 4 presidents. The funding mechanism has been there. These ones have even gone ahead and said, we want to support your structures. Channel this money through government. That is our request. That's what we want. We want to empower KEMSA. We want to grow KEMSA. We want KEMSA to be the only strategic purchaser for commodities, and to grow KEMSA so that it becomes our commodity partner in this country. You understand? And here we are.
Here we are.
Yes, and we insisted. Of course, there were issues about what has happened in KEMSA in the past. We told them, these are clean slate. It's a new relationship. It's a new friendship. Let's have faith in ourselves. There's a lot of reforms going on in KEMSA that people might not know.
We won't see another case of corruption at KEMSA, especially now that money is going to be going direct to KEMSA, SHA, all these other agencies. We
will hear allegations. We'll always hear them. I cannot vouch that you'll not hear at a newspaper headline that X amount of money has been stolen and everything. What will validate us is the finalization of the investigations.
Okay.
And what comes out of it. You understand? Okay. So, and a headline, even today there's a funny headline I've seen in some newspaper. They are talking very negative about, let me not talk about it, but until the investigation and it's over and you prove that, it still remains an allegation. Okay. Thank you.
I was watching the PS Health, Luga.
Yes.
And he said that we're going to be sharing, is it specimens, pathogens?
Very good.
So this, of course, when you share such a thing, it means they can go to the lab, right?
Correct.
So if you have is it a specimen? Let me use the word specimen. I'm not a doctor.
Specimen. It's a specimen, actually.
When you have my specimen that says I have arthritis or whatever condition, it means you can create medication using my specimen to test, right?
There's nothing you can do.
So then are we setting up ourselves as Kenyans as guinea pigs in the US to try and create drugs?
Fantastic.
Vaccinations?
Thank you. So previously, and I thank you for that question, it's a very good question. Previously, the request from the American government was we share specimens. That was the request. Mm-hmm. The government position was we will not share specimens. But if you say we will not share specimens, you might lock yourself out of a nice, previously existing marriage that used to benefit both of us. Do we have capacity in testing and screening all our conditions in this country? No. Do we depend on their labs? Yes. Are those labs in this country? Yes. CDC labs, Waterreed lab in Kericho, Cambry. You understand? Labs that they support. Have those labs helped us in the management of our conditions? Yes. Have those labs helped us in research? Yes. Have those labs helped us in getting to know emerging diseases, what interventions we need to do, research and everything? Yes. Okay. So that has been going on. There were the labs that were testing for COVID, isn't it? We were here. We had a pandemic here, and we used them. So you say no for specimen sharing. What have you just said? Don't test for us any sample. Don't support us. So what do? You say specimen testing. For the purposes of a specimen being required to be tested, and it has met the requirements of Thuranira cannot test it, Sarah cannot test it. The only person who can test it is him, or him, isn't it? We can share a specimen, isn't it? If there's an outbreak today and we have no capacity, they are supporting us. During the 5-year transition, we are supporting transition of some of these structures. If you read through it, the more comprehensive documents even talks about reference labs that we shall be given. We are helping build our capacity. We do not have to depend on their lab. We are transitioning to the point that we are capacity building something like the National Public Health Institute, that within it will have reference labs that can be able to do that work that we are dependent on them. You understand me?
Okay.
So currently, they support us in that space. How do we do it? I have to send a specimen to them. So guys, I have to send a COVID swab to them for them to test, isn't it?
Yes.
Some of these swabs require even genetic mapping. Remember COVID? Most of the test is a DNA test. It's a PCR. We used to call it polymerase chain reaction test, isn't it? We used to map the DNA, and we map the DNA of that virus and say this one is COVID. This one is what? This is this. This is this. That's the testing. That's the scientific testing of this thing, is doing a genetic mapping.
When you do that for a country,
yes,
what does it mean for Kenya, futuristic? Because I feel like we are offering our. They did not want to. They did not want to know where this data came from, but you've just told us some of it involves the genetic. They can easily, from the US, tell this came from some village in Kakamega.
If you read, very good. If you read that, we have tested, we have gotten the results. If you read the data sharing agreement, we have governance around the utility of the data that you have access to. There is, if you read through it, there is what you can do and there is what you can't do. Once you have tested for us, our discussion ends there. There is nothing else.
How will you monitor that? Then they do not have some drugs they've been working on, and they want to test it with my specimen.
I tend to think scientists, this space involves scientists.
Yes.
This space. I don't know if I'll call myself one, but I am a doctor. I took an oath. And the oath that I took is, I always remember it. After my 6 years of undergraduate training, I took an oath that I'm sworn to do no harm and such many things. And it's an international thing. A doctor in Meru, a doctor in Kenya is a doctor in the US. A scientist in Kenya is a scientist in the US. I expect the same code of ethics that govern me in Kenya is the same code of ethics that will govern an American doctor.
So
we read the same oath. So I'm starting on basics. Okay? So basics, I expect the people handling this specimen within this ecosystem are people of integrity, ethics. But also, we have gone ahead and even documented and signed against a document, the data sharing agreement and our cooperation agreement on the utility of the data that you have access to.
That's the best. But you can't guarantee that they
also
test vaccinations with because they have it. Because you won't be in a lab in the US.
We will be here. We are here for 5 years. Yeah. We are monitoring the cooperation agreement. There are things we have to look at on our side. There are things they have to look at their side. There is breach of contract. It's clearly stated in the document, isn't it?
Yes.
And we have agreed that it should be handled diplomatically, isn't it? Mm-hmm. You understand?
But this diplomacy, we are not equals. First.
We don't have to be.
So
you know why we
negotiating? If anything,
so we are not
putting 2 or 8 billion.
Not necessarily. You see, we had a position as a country of bare minimums.
But you signed already.
Listen, our bare minimum was we are not sharing specimens. If you read that clause very well, but for specimens for testing, we are not sharing specimens for genetic testing. Number 2, we have agreed if we have to share data, it has to be aggregate, anonymized data that has gone through the laws of Kenya, and the laws of Kenya agree for us, including consent. Subject consent is part of the laws of Kenya. Under data protection, the data belongs to the subject. Even consent is, you see, when you look at Data Protection Act, below it is everything, including the consent of the patient. We have to satisfy all that before I give out.
But
okay, that's number
said, 2. As a patient, I do not have a say if my data will go either way.
Now you are missing. If you go review them, we have said all the attendant laws of this country. One of the requirements of the attendant laws of this country is the subject's consent. It is legislated upon. So if you request for data, you have written, that is your request. You have written your request. You have brought it here. So this is the kind of data they need. It's analyzed and everything. Now, AG, tell us what we need to do. AG says, one of the requirements for you to give out that data is that it needs to be under ODPC. Anonymized. Okay, it is anonymized. Number 2, it needs to be this kind of data. Number 2. Number 3 is that you have to obtain consent from the subject.
So you will reach out to the patients.
We are required by the we are required by the law. We are not just waking up and saying.
Okay, that is convincing.
Yeah,
if
it is anchored in the law. That's why that statement. Lawyers keep on telling us you cannot legislate on everything. They also tell us that you cannot draft everything entirely in the law. Some things you imply. So if the law requires me, if the law states that the owner of the data is the subject, you cannot jump out of that thing.
Okay.
Very good.
Sounds nice. Now, when there's the issue of either parties wanting to terminate, this agreement may be terminated by mutual written consent of the parties or consistent with the paragraph 4.6 of framework.
Correct.
In the event of termination, access to pertinent data for audit purposes shall be provided to the US government with prior approval from the Kenyan government.
Correct.
So we know Trump term ends before the 5 years.
Correct.
And a new government will come in.
Correct.
Probably the Democrats will probably.
Correct.
And that those guys come and decide, you know what, this Trump thing is this is not what.
And they terminate it.
Yes.
Correct.
What happens?
It's the same thing that happened. The Democrats had their plan, the USAID funded project. Trump's government came in, decided, let's stop this thing, let's reorganize it. Came up, drafted a policy, shared the policy direction of the government of the United States. Came up with an agreement. We drafted an agreement. We agreed on the framework agreement. The next one comes in, decides they're exiting. Well and good. Says we want to run through the process. All eventualities are possible. Upon government changing, we never expected Trump will come and cancel this thing, but he kept on talking about it until the point he came and canceled it. He went and reorganized it. He came back. Why? Kenya is a strategic partner to both of them, isn't it? It's an eventuality we expect with change of government.
What will be the implications?
So what is the implication? Of course, the same thing we did. The other one was stopped. We had to dig deeper into our pockets. We had to get some few job cuts and everything. We had to reorganize. Some people absorbed into government. Some people had to stay at home. I mean, all these things have happened. And we expect... Now, on this deal, if you see especially the most affected, we had to make sure as a government there is no shortage of supplies. Okay, there are some emergency supplies that were present. They went ahead and gave us access to the emergency supply that was not within the hands of government. So we had to make sure status quo remains, even though it means some bending here and there and everything. Now we are back. We are back again under new terms, better terms for Kenya, and we tend to think, even if the new government comes in and stops it, whatever they'll come back with will be a better deal, better than this one for Kenyans again. We have to always negotiate in the best interest of the country. So remember where we are coming from.
Yeah.
Remember where we are. Is it a possibility the incoming government might continue with this plan? Yes. Is it a possibility they might cancel it? Yes. Is it a possibility they might want to redefine it? Yes. What do? We deal with the now. We continue implementing. When that time comes, we deal with the then.
Okay. Part of what was mentioned by the president during the event was that the SHA project is involved in this.
Correct.
How is SHA marrying into this?
So
knowing that we already had the funding of SHA.
Fantastic. One of the pillars of the agreement is something called strategic interventions. And I would wish you open that clause. Strategic interventions are those support interventions, not in the data protection, it's the framework cooperation agreement. Mm-hmm. Strategic intervention are those supporting interventions that shall enhance the priorities of the government. Okay?
Okay.
One of the priorities of government is digitization of health.
Yes.
There's a whole clause on digitization, improvement of the data system in 2,000 facilities. I'm sure you have seen such a thing. Staff that shall be supporting that. If I take you back, is that the American government was supporting systems that are deployed in all what we call comprehensive care clinics, CCCs. That's where HIV, TB patients are taken care of. And that's a system that has been very beneficial to us. It has been reporting data to our big ecosystem. And it's a system we wanted, instead of reinventing the wheel, can we expand this system? Instead of covering only one department in the facility, can it cover the entire facility? So that you remember we have an agenda of digitization of healthcare facilities. We expand that. So we get some manpower to help expand that system, integrate it, data storage, cloud improvement, payment of licenses and that. So that is digitization, and that support goes to DHA, isn't it?
DHA is
Digital Health Agency. Now, SHA has several things. We envision a place where we will integrate the management, what we used to call vertical programs. Vertical programs used to be HIV, used to be TB, used to be malaria. You see, there used to be these projects that are funded this, then there used to be HIV is funded vertically. Money from a donor, from the national government. Commodities are bought, everything is bought, lab tests are paid for. Mm-hmm. It's a whole parallel system. So we envision where SHA has developed a benefits package. The benefits package keeps on growing. And you have to start a package somewhere. I mean, we are here and we got a lot of criticism when we were starting, but along the way, you see, you have been improving. We started with NHIF had no ICU cover. We started with the ICU cover of 4,000 shillings. We realized it's costing a lot of catastrophic spending. We improved it to 28,000. Oncology treatment, we started at a cover of 400,000 shillings. We improved it to 550,000 shillings. His Excellency the President has been gracious enough, and now he has pronounced himself that we have improved it to 800,000. You understand? So you keep on growing benefits. So what would you want to do? You would want an ecosystem whereby we look at this ecosystem wholesomely. You look at HIV not as a separate disease of the benefits that Kenyans enjoy, TB not as a separate disease of the benefits, and you integrate even the management of HIV, TB into these benefits. Is it something we can achieve overnight? No. It has a process. What does the process involve? Costing. The process involves how the integrations will be done. Process involves training of people. Process will involve public participation. You remember even before we gazetted the tariff, we had to take it through public participation. It is gazettement of a benefit as a whole legislative process. Now, what other thing do you need? We have special, I won't call them special interest group, I'll call them vulnerable groups that fall under the programs that are funded under this. HIV patients, TB patients, patient on opportunistic infection secondary to HIV, vulnerable, cannot source for their family. Their premiums need to be paid. They need, apart from this one being taken care of, there's a whole health need around the ecosystem, isn't it?
Yeah.
So this program is taking care of this problem, HIV, TB management, what. There's a whole health ecosystem around that sick patient. There's a wife, or there's a husband, there are children that needs to be taken care of. There is a poor household. You might need to take care of their premiums as a vulnerable group and pay for them to take care of them. Okay? The whole process, I've told you, the whole process of transitioning of a benefits package and integrating them, training and what we do. There's a whole data system. There's a whole system around claim management and everything on the data system. Analytics. We need to do analytics and look at how do we transition these people. How do we need to analyze data to inform policy. Part of that is supported. So there's SHA, I've mentioned DHA, I mentioned KEMSA for commodities. There is what are the others? Strengthening our institutions and there's training. There is minimum number that has been quoted there of officers to be trained, especially in public health and surveillance, field epidemiologists, scientists, doctors. We have healthcare workers who need to be transitioned from program-specific officers to government officers who are paid from the exchequer as part of the national workforce.
Okay. When I look at this document,
Yes.
then I remembered we had an issue as a country some years back. We had Professor Obel,
Yes.
who came up with
The late,
yes, medication for HIV, but it never got to the market because of whatever politics that were involved. When you look at this deal, if a Kenyan professor is able to come up with, I don't know, a drug for
a treatment for HIV.
Yes.
Through research and everything.
Yes, he's done it right.
Very good.
But because the US has signed into this, how will research be allowed, independent
Fantastic.
research, so to say?
So, notwithstanding that deal, a lot of research is going on, including research being funded under this project. Okay? Now, there's a bigger discussion outside this deal that we need to discuss that is housed under the WHO. That has two kinds of things. One of them is what you call the pathogens access and benefits sharing, whereby there's research being done externally or internally. Out of the research, discoveries are made. Part of the discoveries that are made, benefits need to be accrued from those. So there's an ongoing discussion that has been there. It has been quite very hot this year. I remember the United Nations General Assembly, it brought a very heated debate at the World Health Assembly, very heated debate. It is a negotiated thing because different countries are at different levels. So we need to agree. There's an African position. The African position is that if pathogens, bacteria, viruses that within our ecosystem are used for research and a cure is found, notwithstanding the researcher, either is Kenyan or we need to accrue maximum benefits from that research and the findings, if it's vaccine sharing, if it is what. Then we have, so that discussion is going on. There is another meeting in January 2026. There is a committee of experts, very competent team. Kenya has very big team being chaired from Geneva, but including local experts, local researchers who are experts in that whole area of microbiology, virology, and also the benefits sharing thing. And negotiations are going on. It will take some time, and it's good, I tell you, but we need to it's under the pandemic framework, pandemic agreement that was signed previously. So this one should define the benefits to be accrued both ways. Research was done outside based on what benefits come to Kenya. Research was done here. We found this. What benefits do Kenya accrue? What benefits does the rest of the people accrue? So that's a bigger discussion that it's way above this deal. And it's something that you need to keep an eye on. It has been going on for the last like one and a half years, but it's going on very well and it's something we are monitoring.
Okay. Having that in mind, then why would with this deal that is being signed and specimen sharing, why wouldn't it be done by who is already
doing it?
Their work, yes. Rather than, let's say, the US requests a certain thing, then we send to them. Because that's their work.
You remember that President Donald Trump gave his position on WHO.
Yeah.
And you remember that the US declared that they are pulling out of WHO. So The fact that we are members of WHO, does it mean that we don't engage with non-members? No. We engage with countries that are member states and countries that are not member states. The fact that you're a member state under WHO does not limit you from engaging with a country that is not a member state or pulled out of being a member state. You understand? So the engagement, so it's bilateral. It's a bilateral engagement, notwithstanding the confines of what we agree upon in WHO. Of course, a lot of global politics is going on. But within the confines of the agreement, we are not in default with any engagement we have with WHO, nor are we in default with any, what will I call it, global treaties that we have signed.
Okay. America is working with their America First.
And Kenya, we are working with our Kenya First.
What are we working with? Oh,
with our Kenya First.
Because
so what is our Kenya First?
Yeah.
If you go,
second.
Very good. If you go back through the priority items that the President of the Republic of Kenya promised under the Kenya Kwanza Manifesto and what he said towards transition and pillars of delivery of universal health coverage. On several occasions, you have heard him talk about 4 pillars, and he likes talking about it. I can assure you he'll be talking about it even on Jamhuri Day. He talks about human resources for healthcare workers. If you go through that agreement, it has a whole chapter on healthcare workers, how you are transitioning them, how you will pay them. The ones that was offering services under the previous project. That's a priority area we prioritize. It talks about commodity security, availability of medicine, improvement of KEMSA, recapitalization of KEMSA, offering a line of credit for KEMSA to improve the order fill rate, making sure they are medicine under KEMSA. The government positions under that deal is that let us improve KEMSA as a strategic partner for provision of commodities. Second thing under that commodity security is that we got funding to buy commodities under that whole arrangement, and we shall co-finance commodities. So we got more money to get commodities for Kenyans. The third issue, digitization. It's a priority area for this government. Remember, we are rolling out the comprehensive integrated health management information system countrywide. We are currently in over 43 counties. More than 2,000 facilities are live end-to-end paperless. Nearly 4,000 facilities are different stages of rollout. You see the cabinet secretary doing site visits and visiting counties to go roll out. There's a whole topic about improvement of digitization, rollout of the Kenya EMR existing system and improving of that space. Health financing is the other issue. I've talked about support for funding for SHA. It's under. So we know our priorities. We have documented them. We have talked about them. America First has come up. They have come with America First Global Health Strategy. Kenya has appeared in the table. We know our priorities. We talk about them. The president talks about them. They are documented in a manifesto. If you go read the Kenya Kwanza manifesto, they are documented in government documents. The president has talked about them. We walked in with our Kenya First priority areas, 4 of them, and sat down. So commodity, this is our position. This is your position. Let's do this. Human resource, let's do this. So we are championing what we have been doing since His Excellency the President came into government, and here we are. And we'll continue.
What is our health budget? As a country?
Budget as I would wish to... You need to be specific with that answer. Is it the total expenditure?
How much money
is allocated to the
Ministry of Health?
Something between 150 and 160 billion shillings. Ministry of Health. Then there's an allocation that goes to counties, county governments. Then there's a donor component that comes in. There's a contributory component that comes from you. You pay premiums to SHA. We collect like 80, 90 billion. So something like 600 billion entirely in the country.
600 B.
That has everyone.
With everything.
Everything. You have contributed, I've contributed, the donor has contributed. We have all got into this arambe.
So that's it. Is that enough for the need for the health?
Actually, if we reorganize, I'll shock you, if we reorganize the systems and we avoid working into parallel systems. You run a parallel system on an already existing system and you take advantage of digitization, efficiency and everything. We can make do like 350, 400 billion.
Why then?
But we have to do a lot of integration. That's why, again, I come back to our story. Do we need to run HIV, TB as a vertical program? No. What is the request under this framework agreement? Integration. Are we working towards that journey? Yes. Do we need a human resource that is a human resource employed by Kenyan government and another one there being paid by a donor? No. Do we need both of us? Yes. Do we need to standardize our pay? Yes. Do you need you onboarded? Yes. Can both of us work within an ecosystem to make work easier? Yes. Do we need to digitize our systems? Yes. What does digitization do? In this day and age, digitization makes work easier. Data portability. My grandmother from Meru doesn't have to work with a CT scan from Meru to come for a review in Nairobi. Akona mizigo zake and then akona kibasha kikubwa hivi. In an ideal world, within the next maybe 2-3 years, once you have fully digitized the ecosystem, all the data shall be available with you. Upon seeking care, you shall give consent at the health facility for the clinician to access the data. We'll do a lot of efficiencies in this space. We stop spending money on buying paper, printing files, printing reports, doing what. And a lot of savings will come in from there. Okay. We'll do bulk procurement of healthcare commodities. So we aggregate all our supplies as a country because you are digitized in an ecosystem that you can see. The last 1 year, we have consumed 1 million tablets of paracetamol. Then we go to a manufacturer. That gentleman is a manufacturer. Tell him, I come with a demand of 1 million paracetamols. Previously, you were selling for me, because I was buying 200,000, you're selling for me 10 shillings. Me, I have 1 million. He will tell me, I'll give you 2 shillings. You have lowered the cost. If you lower the cost of acquiring, it means even the cost of the drug to the patient goes down, you reduce the cost of healthcare, and you reduce the spending.
That sounds fantastic.
That is the journey you're headed.
With 600,
can I give you examples?
No, wait first. With 600 billion for 1 year, why do we need 208 billion for 5 years?
We have not transitioned our systems. We
cannot do that by ourselves. Like we have to have.
It's a process. You don't switch off the supply chain of HIV drugs overnight. You have been procuring this one. This you have to reassure first. That's a population that you have to keep reassured. That's the first thing. Imagine there was a day there was a news item that there are no vaccines for children in this country. Yeah. Hula baloo, isn't it? We need to.
Hula baloo.
I'm saying there was a lot of noise and a lot of noise in this country.
Yes.
It was true.
Yeah.
Yes, because of what? We depend on this donor funding, this co-financing that is required there. Yeah. We need to integrate these things, sort it out. If the donor delays with his funding, we don't get the vaccine. If the Kenyan government delays with this funding, we don't. Is this a parallel system? It's a parallel system. What do we need to do? Can we integrate these systems to be... they flow. Yeah. Today you're not dealing with vaccination crisis and tomorrow you're going to start dealing. So let me use the issue of commodity, TB, HIV medicine. And what do we need? Look at to enhance this supply. First, you have to make sure there is adequate supplies for the next short, mid-term duration of time, a year, 2 years. So there is no anxiety in this space.
Yeah.
Then you start sorting out the procurement space. That's why you can see even in the clouds, the transition to KEMSA is not overnight. It has a timeline that lapses on 30th of December 2026. We have between now and the next December to do full transition. We might do it in September. We might do it. In between this transition, by the time KEMSA starts the normal procurement process, GP procurement process and everything. These other process has to be going on.
Yeah.
Is this process costly? It is a bit costly. It's more expensive to do it this way than this other way. We have information and data to prove that. Once you start this one, you do the normal procurement, sort of the challenges of logistics. the drug reaches the last mile, the patient gets the drug. Once you clear this process very well, you switch off this system. This system was funded. This system has a parallel distribution pathway. This system has accountability mechanisms. You have to switch off this system, then you pull out this budget.
Okay. I have a very interesting question.
It's more of, if you read that document very well, it's more of a transitory budget.
Okay.
Yes. That's why you see figures start to maximum, they go down to zero. Then the Kenyan figure starts at zero, goes to maximum. So it's a transitionary budget.
And you're confident that Kenya will be funding itself in 5 years?
If we really continue with the momentum we are having, I look at, we rolled out SHA 14, 15 months ago, how much money we are collecting under NHIF, how much money we are collecting now, not only from the formal sector employed, but also from the informal sector. The amount of money we have been able to raise in this big Arambe to help us transition into these benefits. I look at the amount of money that the government has committed to put into this thing. This year alone, we started the first year, primary healthcare fund got, I think, 5 billion. Emergency fund got 3 billion. This year, primary healthcare fund has gotten 13 billion. Emergency fund has gotten 8. Tumetoka 8, tumefika 21. It means there's commitment to keep on improving it, isn't it?
But there should be a question why citizens are not feeling it.
Well, it's a new system. It's a new mode of delivering services. We started with our many challenges, system downtime, understanding of the issue, acceptability. Some providers were not onboarding, we owe them money. So you have to look at the myriad of the challenges. So along the way you build trust, along the way you promise on how to sort out, along the way you help them in you paying them early and such. So we started, you remember 1st October 2024 up to December, the noise was too loud. There is some lull that went on, then fraud came in. I mean, we have all sorts of characters. We made noise about it. And it will take some time to stabilize. It is expected that our biggest goal is that SHA at 2 will be stable, will be no noise ridden. It will have improved benefits. It will be more efficient and everything. We are learning as we move on. Not many countries have done this thing. Not many countries have tried this thing. We have, with the leadership of His Excellency the President, you have decided to take the risk.
Okay.
Let's go in. There was a moral question on 1st of October. So we have costed this thing. We have a benefit that looks like this. It covers bare minimum things. But a Kenyan wants a benefit that looks like this. Do we wait for the day when we can fund these benefits like this? Or do you start with this small benefit that it goes to every common mwananchi and we keep on growing it small, all of us? And that is a moral question. And there's somebody who needs this one. He has never had even this one. But us who are deducted much more money want this one. So what do? You start with this one. We have been growing it, and as you monitor, probably we need to start documenting our phase and how we have been going on. And one day, one time, we'll reach there. No one started this journey overnight. We are just starting building of Rironi, Mausamit Road. Now imechimbwa. Goja.
Let's not go to the roads.
No. Now imechimbwa. In 5 years, tutaona barabara.
We shall be here.
We shall be here.
We will be there.
God is faithful. We shall be here. Thank you.
Let me ask you a very interesting question.
Yes.
You are a doctor. PS Oluga is a doctor. You've said there's a lot of doctors involved in the whole public service sector in those meetings. Healthcare workers. Why do you think the public is not still trusting you enough? Yet we remember your season when you and Oluga were in the KMPDU, you're really pushing and citizens were supporting you and believing in what you're fighting for. But now you're in the system and somehow there is mistrust.
Yes. Very good. So first of all, let me declare that I tend to think me and PS Oluga are very proud of our past. We championed for a better healthcare system. Sometimes you fight and realize probably I need to get in there and do the work. So God was faithful enough to give me a chance, me and my other many colleagues, Dr. Moai, Dr. Chesang, Gibore, to be part of the team that was drafting the Kenya Kwanza Manifesto. These ambitious plans we had when we were in the union, we put them to paper. We talked about human resource. We want a well-motivated human resource. We want people to be paid well. We want commodities to be available. We wrote all those brilliant things. And His Excellency the President won. And he told us, those good things you are writing there? Come and help me implement them. So you got the chance to now, you have crossed over. Now you are here and you have to learn the ecosystem and you have to work through it. And PS comes and join us and other teams join us. Doctors are there. Clinical officers are there. Nurses are there, playing a very integral role. Laboratory people are there. And you craft a new service delivery model. Perhaps one thing we might have missed, and it's good to admit, is that we never did what we call change management. We were used to the NHIF way of doing things. We were comfortable with it. It has helped us and everything. Now we want to reform this system. Maybe we want to take a step back, reform this system, start growing it together. We walk this journey together and we go towards a destination. Basically, people don't take change easily, isn't it? They take some time. People first oppose, people fight back and everything. And as such, we were to do something called change management. Probably our transition was abrupt. We switched off and switched on. Looking back, a few things we should have tied up. We should have worked with the Kenyan. We should have educated the Kenyan. But yes, we started. Now we decided to go back to the Kenyan. We educated the persons who Kenyans listen to. We have had media forums. We have talked to media personalities. We have had political forums. We have educated the politician to go educate his masses. We have educated the religious leader. Is there mistrust? If I look at the data today, over 6 million beneficiaries of SHA. Mistrust, really? The person who has benefited from SHA, you need to call him and to sit here and ask him, do you trust this thing or you don't trust this thing? So we have many skeptics. It's true. Some have never used it. Some have not even registered for it. You understand? But we have a Kenyan who said, let me risk it all. Registered, did his means testing. He was told his premium is 300 shillings. 12 months is 3,600. He paid his premium. He went to a hospital. Unfortunately, got an accident. He's a border rider, went to a hospital, was treated, walked in, walked out. The bill of 336,000 was paid. He walked out. He couldn't afford that thing. You go tell that person SHA is bad, they will even finish you. So it all depends on who you're talking to. I hear a skeptic and I ask them, are you registered? You'll find a cohort not registered. You'll find a cohort that is registered. Very good. Then now you walk the journey of this registered. So tell me your experience. What happened? Oh, SHA ilikata kunilipia. Oh, the benefit. Many things. There's always an explanation to everything. You have walked into a facility that is not onboarded into SHA. They don't want to tell you they have not signed a contract with SHA. They'll tell you SHA is not working. Okay? Because if they say they have not onboarded into SHA, what is the word on the street? Uskaenda kwa hospitali. Susan Hospital. Wananga SHA wapendi. So the word on the street. So I'll package that information and blame the wrong person. You'll go to another person. They have onboarded into SHA. There was some system downtime. They didn't enjoy the services. They were forced to pay. Unfortunately, that one went through that. Then you go to another person who wanted this package paid for, went into ICU, got a bill of $1 million, SHA paid 20,000. Why? We started paying ICU 4,000 per day. That's the only benefit that we had. We had to grow it to 48. You go find an oncology patient. We started with 400,000, 440,000. They have depleted their cover. SHA is not working. The cover, it's a cover per individual. You understand? So there are so many reasons. So what do? We keep on educating people every day. And thank you for the forum that you've given us. We keep on talking to people. You have to keep on. His Excellency the President always tells us, repeat the same thing so many times. There are different people you are talking to every day. The people who watch this thing are not, if I come back to next week, not the same people who watch the show next week. We have to keep on repeating this message. It reaches different people. The understanding is different. We take different times to understand. So we have to keep on repeating these people in whatever forum you get to educate Kenyans. You work with Kenyans. Kenyans understand. Kenyans on board, and we move on.
But I really hope you're taking the feedback also.
We get feedback.
Citizens.
So we get feedback real time. This morning I was reading a Facebook post. I'm in all social media pages. And we even have a media monitoring team that gives us daily reports. What is in the papers? What was reported in the news? What are people discussing in social media platforms? Kenyans express a lot.
Yeah.
So the Kenyan will make noise on TikTok. There's a Kenyan who write a long post on Facebook. There's a Kenyan who will go on X and write a whole long thing. There's a Kenyan who will be interviewed by a media house and everything. We read that thing. We receive that report from the cabinet secretary, principal secretary, the top director, CEO of SHA, CEO of DHA, myself and my colleague, Dr. Moi in the advisory. We receive that report every day. We read it real time. Some things you can fix. Some things is a knowledge thing. Sometimes you find us using our social media pages to educate and respond to a concern. So because that report has come, there's somebody who's just randomly asking a question. How do I pay for SHA? They answered there. Then they also, the toll-free number 147, they call and they complain. They call and say thank you. They call and say I'm stuck. They call like that. So feedback is there. It comes real time. I'll tell you, majority of the feedback is what has made us improve. The feedback from oncology patients, this package is minimal, that has helped us improve the package. The feedback from Kenyans that sometimes the system is down, the system downtime, or probably OTP is not working and everything, that has made us come up with an option of, this OTP keeps on failing. Can we also add biometrics? If biometrics fail, there's a backup plan to go to. So it's the feedback. At a certain point, it is Kenyan feedback that started driving this project. Okay. And it will continue driving it because the pain points keep on changing. And it's a project for Kenyans. It's not a project for 2 or 3 of us. It's a project for Kenyans. They drive it. So like now, there's clamor for improvement of the package for oncology. We tried our best based on the resources available and what we can extend for everyone. We are at 800,000. We are monitoring the utilization based on data. We realize 800,000 is not enough. We add it. Pole too. Pole. Another pain point is a pain point called specialized outpatient clinic. Wale wagonjwa wanaenda, unajua outpatient serikali inalipia, it only pays for it in level 2, 3 and 4. There's an outpatient that is in level 5 and 6. Yeah. Specialized. Anahitaji kuonekana na gynecologist, anahitaji kuonekana. It's also something we're looking at. It's for diabetic patients, hypertensive package. They need a package for their medication. You've gotten that feedback. The actuaries are cracking the maths. Once all that has been done, it will be taken back to the masses and asked, guys, is this what did we understand you that you were saying you wanted this thing? That is, now we wanted all of it to be paid for. Then you come and tell, unfortunately, ile pesa kidogo tumechanga, ile tunachanga kidogo inatosha aka kadogo. Tunaweza anza hapa alafu we grow it. Then they say, yes, continue. So there is a lot of ICU. It was feedback from Kenyans. Oncology, it is feedback from Kenyans. System downtime, it's feedback from Kenyans. So we listen. We might sound sometimes maybe ignorant and everything. The feedback is gotten. This feedback is acted upon. Some takes a long time. Some requires policy directive. Some requires amendment of the law. Some requires an instant thing.
Yeah.
I mean, you're woken up in the morning, there's someone of the system that is down. You just switch off to the option of it. So we have our whole monitoring team that reports 24 hours what is going on in the country, in the healthcare space. Outbreaks, what, accidents, ambulance evacuation requirements and everything.
That's good to hear. I think we'll have another session where we can talk about SHA, because I think today basically was trying to understand this Kenya-US framework deal.
Correct.
And thank you so much for coming to share with us. We appreciate that. Hopefully we will learn as we go, because also there's a whole 37 pages document. I read the 5-page one because it was
Simple.
Yes, it was just broken down.
And the 3 other documents are coming up. We have to draft what we call a financing agreement. Now, financing agreement is putting pen to paper. Hii pesa
inatoka wapi?
Inakuja aje? Inakuja lini? Inaingia lini? Inaingia wapi?
Kuja kutuambia mambo ingine ya daktari. We are not ready.
No, so financing agreement, to prove to you it is a grant, it is not even a loan. It's also something to confirm. Then we also have to agree the implementation roadmap. That one has to be drafted. It has 90 days. If you see through the agreement, it has 90 days. And the last one is the issue of transition. How do we transition? So there's some work still going on. There's a lot of work that has to be done. But let me take this opportunity to tell you that we have the best interest of this country at heart. Nikitoka hii kazi nitabaki kuwa Mkenya.
Of course.
And maybe nitarudi huko kuwa activist. Or maybe I will retire and go and chill there and raise my children and everything. I'll be asking myself in the year 2025, November, December, did I do the right thing for this country? When that document was shared, I was monitoring the sentiments of Kenyans. And I was very proud of our team. First, we never leaked the document during the time of negotiation. Number 2 is that we all waited for... The urge to leak the document is always there with Kenyans. We have to wait for all the legal requirements to be fulfilled for the document to be shared. And number 3 is that the government of Kenya, through its cabinet secretary, honored their word of sharing the document. Hakuna siri. Document mko nayo. Yes. So we couldn't share there. Of course, there are many other government protocols that have to do. The American government also has to give us permission to share. Remember, it has their signature. So there's small, but it took a very short time. Thursday, people traveled on Friday. Saturday, landed here till weekend. Monday kabla isha mko na document. And thank you very much, Alfa House, for having me.
We totally appreciate your time. It's been a good time learning and trying to understand what is going on. Of course, even as we go, even as you release those other documents, we will reach out to, get more information, because I think the biggest and the best thing is to communicate to the people, because we must understand. And especially if we're going to fund it in the budget, that means we have to pay our taxes.
It's your money. It's our money.
We must understand. And also, thank you for sharing, although it was rather expected. It's a must. It's for the citizens. It's for country. Stay woke. Keep watching those things that government is doing.
And keep criticizing.
And keep critiquing. It's very important, even for improvement.
It keeps us
to keep them
accountable. We keep awake.
We must keep our government accountable at the end of the day.
Thank you so
Daktari,
much.
Asante sana.
Asanteni sana. Good job, eh?
Thank you.
Na mniajiri hapa mkimaliza hii kazi. I can be your health consultant.
Personal doctor. We need that. Thank you.
Thank you so much.